Welcome back to another episode of the Fracture Files, the silver linings of geriatric fracture care. My name is Megan Sorich. I am an orthopedic surgeon who specializes in geriatric fractures, and I work at UT Southwestern in Dallas, Texas. Today we have Dr. Carmen Quatman, who joined us.
Yeah, good morning, Megan. I'm Carmen Quatman. I'm an orthopedic trauma surgeon and also a geriatric specialist. I also do a lot of research in geriatric orthopedics, so I'm really excited to be a part of this today. I work at The Ohio State University.
So today we're going to talk about the different types of hip fractures. Hip fractures are challenging because we don't always know what is a hip fracture? How do we define what a hip fracture is?
Yeah, that's a great question. I usually try to bucket it into mostly when we call it a ball and socket joint. So the ball is kind of that kind of round part of the hip, and the femur part, which is this, it's a stick essentially. And there's a lot of different fractures that can occur in that area. And I want to also emphasize that sometimes people bucket the socket part as part of the hip fracture, but I think today we're going to focus just on that ball and socket part, or the ball and the shaft part, because those tend to be where we see the most fractures occurring. Megan, do you want to describe a little bit about the ball and socket joint?
Yeah, absolutely. So sometimes when we talk about socket fractures, we're more talking about pelvis fractures. So the ball, as Dr. Quatman was saying, is more the hip fracture that we're talking about. So if you think of the ball and you could kind of divide it almost like an ice cream scoop, you want the ball or the ice cream scoop to stay on the cone or the upper part of the thigh bone. And so when that ball slides off the cone, we call it a femoral neck fracture. And then as we march down that ice cream cone, the next place that is the most common place to fracture for your hip would be an intertrochanteric hip fracture. And then even further down would be a subtrochanteric hip fracture. And these are treated kind of similar but different ways. Dr. Quatman, how can you expand on that?
Yeah. So I like to start with just talking about if you fracture the ball part of the joint. So we bucket these as what's called a femoral neck fracture. So there's an elongated part of the femur that inserts into that ball, and you can fracture right at the edge of where that ball part happens, almost like if you were a golf ball and a tee, and kind of like that separation between the golf ball and the tee. You can actually fracture in the T part. So we have what's called an subcapital femoral neck. That's where that separation happens at the ball and the tee. We have any type of fracture that we can bucket into what's called the intracapsular fracture. And so that's any other part of the neck, really, region. And this is really important for us as surgeons because it helps determine the type of implant we know might work well. So if you fracture just the ball part where it connects to the T, we can sometimes fix the ball and the neck part with screws. But this is really only effective if it's been minimally displaced and if the healing potential is high for this patient. So what we don't want to have is vascular disruption to that head. The chances of them healing that fracture with just a few screws or some type of small implant, it doesn't do well. But if someone fractures there, we'll either put them in a bucket where we fix them with screws or a small implant, or we convert into what's called an arthroplasty or a joint replacement. And so that's why it can be a big surgery or smaller surgery if it's that ball part of the joint. If it's in the intracapsular region at all, we do worry about healing potential because that means that they might not have blood supply going to the head. However, there are a number of extracapsular, or kind of the different regions that Dr. Sorich explained, where the inner troch, or the kind of more outside part of the hip, is fractured. And those are really not necessarily as amenable to an arthroplasty or a total joint replacement, but instead we will often put an intramedullary nail in that area, or something called a sliding hip screw. So we choose our implants based on the fracture. Those implants are really important and have been well studied to determine which ones are best for which fracture. And I'm going to add another fracture in there that we didn't really describe, which is something called a periprosthetic joint, periprosthetic fracture, which means somebody fractured around the implant. So that's not something someone has on their first go round, but if they've had a total joint in place, or if they've had some type of fixation around there, you can actually fracture around the hardware too.
Yeah, that's a great point. I feel like sometimes we get a lot of questions of my friend had a hip fracture and why didn't they have an arthroplasty or why didn't they have a hip replacement? And as Dr. Quatman was explaining, it's really based on the location of the fracture. That's how we decide the implant choices and also the displacement. As that ice cream or that ball kind of slides off the cone, we are concerned about the blood supply disruption, and that would make you eligible for a either half of a hip replacement or a total hip replacement. The difference between half of a hip replacement and a whole hip replacement is if we replace the socket or not. So the fancy words are total hip replacement versus hemiarthroplasty. And we judge that based on patient's activity level, if they have pre-existing hip pain or pre-existing hip arthritis.
Um, Dr. Sorich, why would you pick a hemi or a total specifically? Is there some reason that someone might be a better candidate for a total joint versus a hemi?
Yeah, absolutely. So you look at patient's activity level and also pre-existing arthritis. I don't usually like to use age as a criteria because some of our healthiest patients can be well into their 80s playing tennis or golf on a daily basis. It's really based on activity level and arthritis inside that ball and socket.
Yeah, absolutely. Some of the reasons I might choose a partial hip replacement or a hemiarthroplasty instead of a total joint, though, is if someone has a risk for dislocation. The exposure that we have to do for a total makes us have to take down a little bit of more of the soft tissue, and that can put them at risk for a bigger dislocation. The other thing that's really interesting is we have several different approaches to the hip. I personally, I love to do what's called a posterior approach for different reasons, but others might select a different approach. I'll tell you my reasons for posterior approach is because if anybody ever needs a revision surgery, if something happens, that tends to be the exposure that we need to get it into that joint. It's also allows us to get really more global access to that joint in different ways. So it's just something I feel more comfortable with. I've done a lot in my practice. I've done the other approaches, but this one, it tends to be the one that I lean towards. What about you, Dr. Sorich?
Same. I really like the posterior approach. Older literature showed that posterior approach had a higher dislocation rate, which has been debunked recently. They all have pretty similar dislocation rates, especially when you repair the capsule in the posterior approach. Some of my colleagues use a lateral approach. I don't love the lateral approach because you do have to take down a large muscle group, which usually leads everybody with a limp afterwards. And I kind of make the joke, if you had a fall leading to a hip fracture, I don't want to give you a limp afterwards. And then there's also the anterior approach, which is more common in a total hip arthroplasty because it's easier access to the socket, but it could also be done with hemiarthroplasty as well.
Yeah, no, absolutely. And, there's different reasons people might choose. I think it's really important to choose the one that you feel comfortable with, that you feel like you can get access to. I've had a real struggle with the anterior approach sometimes, and some of these patients who have contractures, if they've ever had some type of Parkinson's disease, or they've been bedbound for some reason, you can see pretty significant contractures. And I feel like with the posterior approach, I can actually get the access I need, and I can also do some takedown of areas that might be scarred that allow for better, not only for better retraction during the surgery itself, but also to help improve contractures that they may have.
Yeah, that's a good point. Our friends that are sitters for a long period of time, whether they're wheelchair bound, bed bound, just don't walk as much, sometimes they can get their hips and their knees stuck in a flexed position, which does make different approaches quite challenging.
Yeah, yeah, it's a great point. The other thing I really think about, and this may, you can have different reasons. Sometimes certain approaches are safer for the patient. Like if they can't be prone or in the lateral position, but they can be supine, they might be a candidate for an anterior approach. Prone means sitting on their belly, basically during the surgery. And the lateral is we actually have them sitting up on a lateral position. I do all of mine in the lateral position. Or if we needed to do it supine, we might put them on a fracture table.
Yeah, absolutely. Yeah, same. To get to the posterior approach, it's usually easier to do them in the lateral position. But that's a good point for anesthesia risk, for other reasons that people can't be on their side. There's always another option, and that is the anterior approach.
Yeah. Let's talk real briefly. Cement or no cement?
Cement every time. So I like to cement most all of my arthroplasty. And the reason for that is there's a reason that the bone broke to begin with. That bone is probably quite fragile. And I don't trust a press fit, or I don't want to explode that bone. There is a risk of cement, especially when my friends that have lung conditions, pre-existing problems with their lungs or breathing. But I'd say 9 times out of 10, I'm cementing every time. What about yourself?
Yeah. So cement, for those who are not familiar with some of the surgeries, we basically like to pot the implant into a cement around the bone because that helps create a better interface. Um, in the press fit situation, we actually have to rely on something called hoop stresses, where we impact the implant and expect the bone to stretch ever so slightly to kind of hold that implant. The problem is the older we get, the more at risk we are for osteoporosis. And that can lead to a fracture, not only in the operating room, but even in the short term. If that implant toggles at all because they don't have great bone, the implant can do what's called subside. So kind of slip down further, or it can actually cause a fracture down the road. So I am a 100% cementer. I do it with every hip fracture. I will say that sometimes we have different ways of leveraging the cement. So you can do what's called pressurizing the cement, where we use a special gun, for lack of a better term, to pressurize the cement and take out the air and kind of push it really, really tight into the canal. Or sometimes I don't do that. If I'm really worried about the patient, I will use just thumb pressure. So I would basically just mold the cement into the canal. And so it really depends on how sick the patient is, if I'm very worried about the cement, but I use cement every time.
Yeah, I agree with you. I do not pressurize the cement. I use thumb pressure just because I am worried about lung problems and lung after effects. Absolutely.
Yeah. So we put cement in the canal and we embed that implant, and we kind of acknowledge that we have a risk that the bone now with that implant and cement around it is hard compared to softer bone. Is there anything you do in the postoperative period in these patients to try to prevent future fractures?
And I afterwards they walk. They're up with therapy every time, working on their balance. We talk about bone health prevention. We do bone health labs, and really use the analogy. We go to the dentist to prevent cavities. At this point, we really need to talk about bone health prevention and things that they can do to prevent future fractures, whether that's grab bars, throw rugs, bone medications to make their bones stronger. Those are kind of my strategies to hopefully prevent future falls.
Yeah, that's great. And we can talk about that at a later date. But I think that that's really important, regardless of if we did a total, a hip hemi, or any other implant. So if we don't do a arthroplasty, which we were just talking about, what are some of our other options?
Yeah, other options when we're talking about the intertrochanteric hip fractures or even the subtrochanteric hip fractures, you could use intramedullary nails or rods. So these are titanium implants that go on the inside of the femur bone, and they help control rotation and help kind of stabilize the fracture as the patient heals around the bone. The other option is an open reduction internal fixation using plate and screws on the side part of the femur bone.
Yeah, those are good explanations. I once did an experiment with some fourth graders actually, that I had them grab a straw and in a bigger straw, and then we inserted a pencil down. So they tried to bend it without anything in it, and then we put a pencil down it, and we had them try to bend it and show how much harder it can become once we fill the canal. And so that's a really good, I think, generalization of what happens if we put an implant down the canal of softer bone, is we really kind of brace the whole bone, which is nice. We have an option for longer implants and shorter implants. Historically, in my training, we always put long intramedullary nails in, but I have to admit, the literature's been pretty convincing. So I've moved towards doing shorter nails. I will sometimes do what's called an intermediate nail. If I think they need more bone stability, or a short nail. How about you?
Yeah, so I kind of look based on the fracture. So if it's a stable fracture and the fracture doesn't propagate that far down the kind of upper part of the thigh bone, I like using short nails. In my mind, I look at if they broke below a short nail, I can fix that easier than if they broke below an intermediate or a long nail. I always plan for the next surgery, but hope to not need it. And then if the fracture is in the subtrochanteric range or again further down the femur bone, then I use the longer nails. I don't tend to use the intermediate ones as much.
Mhm. Yeah, I've kind of the intermediate nails have grown on me. I wasn't doing them, but sometimes I've had patients that have been on some type of bone health medication or just some type of anatomy distortion where they have a curvature to their bone. So that intermediate nail makes me feel a little bit safer with those ones that have propagation, but I don't feel like I can embed a long nail all the way down.
Yeah, that
What are
makes
the
sense. It's a
Yeah.
good option.
Yeah. For those who've never put a nail in place, what's the benefit of a short nail versus a long nail surgically for us?
I think surgically there isn't a whole lot difference except for to get a long nail down inside a femur bone, we do have to incrementally ream or make sure that the bone is able to accommodate that rod or that nail inside the femur bone. So it does add a little bit of time to surgery, but probably like maybe 10 minutes tops. You also increase your blood loss a little bit more. And you also can get some thigh pain when we do put that nail down the length of your femur bone instead of just the top part.
Yeah. And most of the systems out there, because there's a lot of different companies that make nails, the short nail and the intermediate nail have what's called a jig attached. So they can basically predict the trajectory of where you need to put screws in the distal part of the implant. So you can make a small incision in the skin and it kind of directs the screw in the correct location. It's much more challenging to do that with a longer nail. They haven't been able to develop jigs that do that as accurately. So instead, we do what's called a perfect circle technique where we have to use X-ray. So there's also the disadvantage of that it can take a longer time to put those screws in the distal end of the nail to give you control. And I just want to add to anybody who's never really seen this before. So our implants, we usually have a long rod that goes into the femur and then at least one screw that goes up into the head of that ball that we talked about, up through the neck and the ball. And then distally, we usually put something to try to help with rotational control of that implant because these nails in an older patient don't necessarily fix in place very well. And so we will usually put interlocking screws down in the more bottom part of that implant as well.
Yeah, inside the femur bone, usually the nail does not fill up the entire space. My analogy is it's a hot dog in a hallway. So that's why those screws are important for that rotational control.
Absolutely. Um, for anyone who is a surgeon, any tips or tricks that you like to think about with tough tough intertrochanteric or subtroch hip fractures?
Yeah, so for subtrochanteric hip fractures, I tend to go lateral because that helps me with the reduction instead of supine. So you could either place the patient on their back or on their side. For a bad subtrochanteric hip fracture, I will open it to help get my reduction. Sometimes I'll use a mini frag plate just to hold the reduction temporarily if I don't have a lot of hands or residents to assist. But I feel like those are the ones that keep you awake a little bit longer to plan, to they give you a little bit of anxiety. Those are hard fractures.
Definitely notorious, you know, tough ones are the subtroches. And we try to educate our residents about, you know, not every hip fracture is the same, but the subtroches are particularly tough. And getting them reduced can be really tough. And some of the most tough ones are the ones that have been on a bisphosphonate, for example, and developed that atypical femur fracture, because you have to worry about getting the reduction right and the bend in the bone that may have happened over time. So that'll have to be a discussion for another day for sure. But
Yeah, but those are hard.
totally. One of the things I really like to emphasize is your starting point is critical on one of these, on many of these trochanteric fractures. So there's a lot of comminution and sometimes some significant lateral wall missing or at least fractured. And so it's really important to get a good starting point, but that can be almost impossible to achieve if there's no bone over there. So there's some things I like to do if I encounter these, and I feel like I'm encountering them more and more. I personally like to use what's called an awl that lets me get my starting point up and over almost into the beginning part of the neck to make sure that my implant doesn't fall into the fracture site. If I can't avoid that, I really I will do a core reamer to try to help direct the trajectory of the guide wire. And I really emphasize to the residents that this whole time we have to be pushing our hands in to avoid a varus posture of that nail. So kind of like you're emphasizing medializing the area where you're entering in the implant. And this can be hard and soft tissue if the body habitus does not really allow you to. So another trick I love to pull out of the core is they make these gigantic retractors that are big, what we call riches. And instead of using that, what's called a spoon or something like a metal thing that they try to avoid, you can actually have someone push in with these very large kind of rich retractors and really allow you to get that medialization of your implant. But it's something to really watch even throughout the cases to not let that implant fall into the lateral posture up at the where the fracture is, because that will be catastrophic and often require a revision. So
Yeah, those are some
starting
great
point, starting
tips.
point, starting point. Yeah. Also, I guess for everybody else to hear, there's something we emphasize to residents called the tip apex distance. You want to talk a little bit about that?
Yeah, so the tip apex distance was first kind of talked about when we talked about a different implant called a sliding hip screw. And it realized that they want the screw to be as close to the really that almost the hip joint itself. And in that great subchondral bone, because that reduces their pull out or kind of the failure rate of these hip fractures. And that's been extrapolated to using these intramedullary nail devices that you want your screw to be center in that ball, just to have the most optimum outcome. And again, kind of nice and deep in that good subchondral bone.
Yeah, excellent points. Do you ever put cement up into the femoral head with some of these implants? And we can maybe describe what that is.
Yeah, so interesting. I did a lot of that during my fellowship, and I have not done that much in the last 5 years since I've been here as an attending.
Yeah.
So I feel like I think about it a lot. But to be honest, I have not used it much. How about yourself?
So just for the audience, what we're talking about is many of these implant systems have holes in the screws up at the top where you put the screw into the top of that hip ball there. And with those screws, it allows you to kind of extrude cement and fill in areas that may have bone loss because of osteoporosis. I've been a little bit reluctant. I've used it a lot, but it's very case specific. So I've used it in places where, for example, someone had osteogenesis imperfecta, and I didn't know that their bone was going to be good enough to hold the implant that I need to put in there. which worked wonderfully. I've used it in a couple of places where we've had to revise a nail because they failed in some way or shape or form. So there's a big hole in the bone that has to have kind of to avoid cutout and toggle of a screw. I will backfill it with that. But it's not my first go-to. I have to have a good reason to use it. Some reason where I'm concerned that the implant's going to need a little bit extra fixation. My biggest worry with using it, honestly, is that if they ever did develop an infection, trying to get that out would be almost impossible. And so I try to avoid it in those cases. And you definitely can't use it if the fracture itself or the during your surgical implant, you've breached the joint line at all, because that cement can be extruded into the joint. So you have to be very, very careful in your case selection for that.
Yeah, but that's a great tool to kind of have in your pocket for those patients with poor bone or concern about implants. That's a great option.
Yeah, absolutely. Let's see, any other thoughts you can come up with? I think I'll add that when I have to say you have a fracture around an implant, one of the biggest early mistakes people have made is that they think that they don't have to put a big implant to bypass the fracture, that they can kind of get away with kind of smaller implants and surgeries. And for me, it's really critical when you have a fracture around another implant the next surgery is really important. Most of the time we can fix them with just another implant alongside of that. Sometimes they need a replacement, but much of the time you want to make sure you have really good working length across both the fracture site and the other implant. So it's not just, implant, a little bit of bone, implant, or you want to make sure you have overlap of metal. So I hate to say like overload them with metal, but you want to have really good working length of those implants and make sure that you have good fixation of both the fracture and coverage of the other implant you're trying to brace around.
Yeah, that's a great point. In fact, I feel like those are so challenging. Maybe we'll have another session just talking about periprosthetic fractures and kind of challenges and tips for success.
Yeah, that sounds great.
Well, that just about wraps up our time today. Thanks so much for joining us, Dr. Quatman. And again, thanks for joining us on another Fracture Files session. We'll see you next time.